Okay, so I guess this is take 2 or 3. I got to about the 3rd or 4th slide and realized that my microphone wasn't turned on. Alright, so we're going to start the cardiac output part 2 today. This should be for Tuesday the 21st. But before I get going with the lecture, I just kind of want to go over what's under course content. So if you open up your course content, you see day 3 and 4. Basically because it's a continuation of the lecture, and with all the presentations that I've been doing, you still have the original copy of the PowerPoint that we would normally see in class. So if you click on the first part there of the course content under day 3 and 4 cardiac output PowerPoint, that would be the original one that you would see in class. And for this particular second half, I advise after you're done listening to me talk, you go back and find the video links. They'll all be highlighted in blue, the YouTube video links that I'll be referring to in the audio part here, mainly because it's unclickable, I believe, in this format. So if you go back, maybe when you get out of this screen, I'm not sure how it looks for you, but if you just go to the original PowerPoint, you'll be able to click on those video links. There's probably about 4 of them, maybe. You also have your homework assignment, which is due on the 22nd, which is Wednesday. Then you have an MRE scheduled for today, the 21st, if you're listening to this on Tuesday. I also have included a video link, Hemodynamic Principles by Janice Provitz. It's a little supplemental video. I think it kind of puts everything together a little bit with graphics at the same time as she's talking. It's kind of colorful. I'm hoping that will help kind of glue everything together for you. And then I also added a article. It's a pretty short article, like 3 or 4 pages, talking about SVO2 measuring, which I talked a little bit about at the end of today's PowerPoint. But it just kind of explains the use of SVO2 monitoring as a non-invasive way. I think it's a helpful article. And I have a I have a discussion board posted for you. I went ahead and put all your names up there so that you can put your post after you're done reading it. I'm sorry, it is invasive. Just as I'm looking at this again, it's invasive. The true venous sample is actually from the tip of the catheter. But read the article, post your whatever your thoughts are on it. Just one post is good. It's fine. If you want to continue dialogue, that's great. But I'm just requiring one post. All right. I think that kind of sums up what I want to say at the beginning here. So you'll see day 3 cardiac output part 1, and that's your YouTube video link for that first part of this lecture. And then day 4, which is today, it'll say cardiac output part 2. All right. So we are looking again at afterload. I know some of this is repetitive, but that's kind of how we learn best, is repeating all this, adding, I think, sprinkling a few more details as we go. So overall, when we look at afterload, we would like it to be low versus high. Okay, we don't want to have as much force. We want to keep it on the lower end. So this is based on 2 different components, the ventricular wall tension and vascular resistance. So remember, afterload is that force, the forces that impede the flow out of the heart, so what the heart has to push up against. Okay. Right. So things that are going to increase the afterload. Okay, increased afterload is ventricular overdistension. So if we have to push again from too much pressure and volume, ventricular overdistension then will increase the tension in the muscle, and more energy and oxygen is going to be needed for the contraction. Okay, so it's over distended because it has had to work too hard. Okay, so it's had to push against too much pressure and volume. Okay, so things that would help decrease in that afterload is going to be vasodilators. It's going to open it up. So again, you think of like a hose, for example, with a small diameter, or anything with a small diameter is going to require more force or pressure to get beyond that narrowing. So if we vasodilate, that can help decrease our afterload. It may also help improve our stroke volume, but it can cause a decrease in blood pressure if the blood volume is too low. So that's one of those balancing acts, and yeah, as you see, a lot of the medicine that we practice is a balancing act. You know, 2 steps forward, 1 step back type of thing. We have to kind of, you know, everybody requires a delicate balance, some more so than others. Things that decrease the afterload, so positive intrathoracic pressure favors the compression of the ventricle. So the decrease the pressure gradient across the ventricular wall, so that decreases the pressure gradient across the ventricular wall and decreases resistance to ventricular emptying, but at the same time it opposes right ventricular filling. Okay, so you have to look at preload and afterload are kind of like they work opposite of each other. Okay, so that negative pressure can increase the preload, but it makes it harder to push all that extra blood out for the afterload. Okay, so for patients with CHF, IPBB and PEEP may actually help them because it helps compress the heart during the inspiratory part. Okay, reduces diastolic filling, but at the same time it can enhance systolic emptying. Okay, so afterload also decreases as the ventricular muscle increases. So a stronger heart does not have to have as much force as a weaker heart to, you know, empty out that blood or to contract. So cardiac factors that decrease ventricular emptying include ventricular overdistension. Okay, so you think about that, the heart is overdistended, it's probably has like a degree of cardiomyopathy to it, it's weaker, abnormally high intraventricular pressures, thinning on the ventricular wall, again that might be related to a weak muscle, and then negative intrathoracic pressure. Okay. So vascular resistance, peripheral vascular resistance, is then determined by elasticity of the vessels. So we look at that as compliance of the vessels, the size of the vessels, okay, again the diameter, the radius of the hose, the viscosity of the blood, and then the change in the pressure or the driving pressure. So when we look at the radius of the vessel, obviously a decrease in the radius is going to make the heart work harder and is going to need more energy to eject that blood. As afterload increases, the myocardial oxygen demand of the heart is also going to increase. So when the heart doesn't have enough oxygen, it isn't able to produce the amount of energy to efficiently eject the heart against the afterload, and then the failure worsens, and then this creates a downward cycle that keeps happening if the afterload isn't decreased. So this cycle can be broken if we give supplemental oxygen, which helps provide increased energy and is going to decrease the afterload. Again, those vasodilators help it so that the vessel isn't as tight, so it doesn't require as much pressure. And then, of course, a balloon pump would also increase contractility. Viscosity can be a problem because if we have thicker blood, the heart's going to have to work harder to push out the blood. So we think of polycythemia, those types of patients, the heart has to work harder. And then blood flow, when back pressure increases in the venous system, it decreases a pressure gradient across the capillary bed, and the decrease in flow then increases our afterload. So this occurs when the right heart is not able to pump out the blood efficiently. Then the flow from the arteries through the capillaries to the venous system slows, and this then creates a damming effect, which causes then the afterload to increase. So everything ends up backing up. So this is also explained, so you know, in your textbook on page 360 and 361 in your Wilkins. Okay, so again, decreasing that vascular resistance would be done by giving vasodilators. Okay, so that increases basically the size of the container. Okay, if you kind of think of it that way. Remember though, vasodilator decreases afterload and then therefore decreases energy demands of the heart. It also increases the size of the vascular container by dilating. So if the container is made larger but the blood volume stays the same, the amount of blood returning to the heart, or the venous return, decreases, and preload then also decreases. Okay, and then our stroke volume is going to decrease. So kind of keeping in mind that's kind of where that balancing act is important. So again, we have two types of vascular resistance. We have pulmonary vascular resistance and systemic vascular resistance. Okay. So this, I just want to add a couple other things here. Calculating systemic and pulmonary vascular resistance. So systemic vascular resistance, remember, is a measure of resistance to blood flow through the systemic circulation. Systemic vascular resistance increases with peripheral constriction, that makes sense, and occurs with hypertension. So then, and the use of vasoconstrictors. So anything that's going to constrict the vessels are going to increase that systemic vascular resistance. And then pulmonary vascular resistance is a measure of the pulmonary vascular resistance and increases with pulmonary vasoconstriction, which you're going to see in hypoxemia and acidosis. Okay, so that's where a lot of patients can develop pulmonary hypertension from OSA. Okay, so they have decreased oxygen and even possibly become acidotic. So things that can decrease in our pulmonary vascular resistance can be oxygen, calcium channel blocking agents, and isoproterenol. Now you're going to want to look at Desjardins, because I think that he does a good job of explaining this. It has different charts and that, and kind of helps classify things and put them in different groups, and that easier to read, I guess, if you look at page 492 in Desjardins. So this can help. So we again are looking at pulmonary vascular resistance, and this is kind of a review from the last time that I spoke. Again, it's looking at the right side of the heart. Okay, reflects the afterload of the right ventricle. Your normal numbers are 110 to 250 dynes per second per centimeter to the fifth. Again, this is taking mean pulmonary artery pressure minus your pulmonary capillary wedge pressure. So, and then divide by cardiac output times that 80. Okay, remembering that the 80 is your conversion unit to dynes. Okay, so factors again that are going to increase your PVR, things I just mentioned: hypoxia, acidemia, CO2. So those are chemical. Okay, you kind of breaks these up in different categories. So you have the chemical ones, and then mechanical, vent, and for CPAP and PEEP, so hyperinflation of the lungs can also increase your PVR. Drugs such as epi, norepi, gelbutamine, dopamine. Vascular blockage, that's like a PE. Vascular destruction, again we're thinking of emphysema and pulmonary interstitial fibrosis, and vascular compression as a hemo and a pneumothorax. And then again, so things that we would do to help interventions would be oxygen, calcium channel blocking agents, and isoproterenol. Okay, so again, 492 and 493 in Desjardins should be your friend here. So when we're looking at systemic vascular resistance, that's a higher resistant system compared to pulmonary being a lower resistant system, and this is reflecting the afterload of the left ventricle. So your numbers are going to be higher. You're looking at your mean arterial pressure minus your CVP divided by your cardiac output. Sorry, that's a little off center there. So in things that are going to increase your SVR, again, are things, just think of things that constrict. So vasoconstricting agents, dopamine, norepi, epi, hypovolemia, late septic shock, decrease PCO2. And things that would decrease your SVR would be vasodilating agents, so your dilated things, you don't have as much pressure. Things such as nitroglycerin, nipride, should be nipride, morphine, hydralazine, early stages of septic shock, and increased PCO2. So these again are found in Desjardins. Okay, so the final factor that helps determine pump function is contractility, or the force of the contraction. So this is influenced by the cardiac muscle and the inotropic state, or the contractility state. So this is independent of preload and afterload. So the ejection force is moving preload out against afterload. Okay, so decrease contractility. So things that are going to decrease the heart's ability to contract is going to be an ischemic heart, hypoxia, acidosis, electrolyte imbalances, and decreased sympathetic tone. Other things as far as electrolytes would be a decreased potassium and decreased calcium, and again an MI, whether it be infarction or ischemia. So things that are going to increase your contractility then would be inotropes. Okay, so dobutamine, epi, dopamine, norepi, and calcium. Sorry, my papers are shuffling around here. All right, so now we're looking at 5 different factors then that affect our contractility. So sympathetic nerve stimulation, that stimulation then releases norepi, which is then going to increase your strength and your rate. Inotropic drugs, things that I've already mentioned, that affect the strength of the contraction. Positive inotropics increase the force and the velocity of the contraction, and they also increase myocardial oxygen consumption, so keep that in the back of your head. And those are medications such as DIG, epi, norepi, dopamine, dobutamine, amurone, isoproterenol, and caffeine. Okay, so these should be at your bottom of your footnotes. So again, if you look at your first PowerPoint that's listed, the one that we would do normally in class, these should be all listed in the bottom. These are the added speaker notes. Negative inotropic drugs, so things that would decrease the strength of the heart, decreases contractility, but they can still, but they also may decrease myocardial oxygen demand. Okay, so that could be helpful. Would be beta blockers, barbiturates, and many antiarrhythmics such as procainamide and quinidine. Physiologic depressants, physiologic depressants such as hypoxia, hypercapnia, and acidosis. Okay, so these are things going to affect your contractility. These are physiologic depressants, would be hypoxia, hypercapnia, and acidosis. Things that have damaged our heart, such as damage to the myocardium, valves, or conduction system, which then reduces the pumping ability of the heart. And then blood flow to the heart itself. So when mean arterial pressure decreases, perfusion is going to decrease. So oxygen delivery decreases and the contractility decreases. So we have a decreased myocardial oxygenation happens in an MI. So contractility is dependent on oxygenation, or SAT, or hemoglobin, or coronary artery patency, so how are our vessels in our heart itself, and our diastolic blood pressure, our resting blood pressure. Also looking at our electrolyte balance, our pH, our preload and our afterload. And also keeping in mind that a decreased, I think I mentioned this on the previous slide, that decreased potassium and calcium can also decrease your contractility. I know it's a lot of information, but hopefully you can access that on the bottom of those slides. All right, so contractility. There is no absolute direct way to measure contractility. Stroke volume can kind of give us an idea of the overall overall heart function, as well as ejection fraction, cardiac work, and stroke work, but there's no absolute direct way to measure contractility. So on the next few slides now we're going to be talking about invasive and non-invasive cardiac output monitoring. Okay, so the first one that we're going to be talking about is non-invasive. So I just spent about a slide or so. Your textbook and cardiac output, I believe that's chapter 16 in Wilkins, has a couple paragraphs on each one of these. Yeah, chapter 16 on each one of these types of monitoring. So we have the transthoracic electrical bioimpedance, echocardiography, radionuclide cardiac imaging, and estimates of cardiac index from pulse pressure and partial CO2 rebreathing. Don't get too overwhelmed with this. I do have video links. This is where you're going to see most of your video links to kind of help explain these two. But I want you to be aware of them, but you're not going to have to know them super in depth or anything like that. Okay. All right. So transthoracic electrical bioimpedance. This actually can provide real-time, continuous real-time, non-invasive measurement. It basically translates electrical activity into blood flow. Cheetah is a brand of the Cheetah bioreactance video. I included the link here with this, so again, I don't think you can click on it from here. You'll probably have to go, or maybe you can. well, otherwise go to the original view of the PowerPoint. This one's kind of cool. I've actually seen this at Good Sam's. It uses these different electrodes they put on the patient, and it can kind of help see if they're volume responsive. Okay, so it provides continued real-time non-invasive measurement, measures blood flow, left ventricular performance, pumping efficiency, and volume status. It translates into blood flow. These 8 electrodes are placed on the patient, digitally displays variables including cardiac output, stroke volume, heart rate, ejection velocity, ejection time, and thoracic fluid index. It can be difficult to use in patients that are septic, that have intracardiac shunts, that may have arrhythmias, and hypertension. So it kind of has limited widespread clinical use. But definitely watch the video. I think it's pretty cool because it can tell, can help see if they're going to be fluid responsive if their blood pressure is low. So definitely have seen that used. Alright, echocardiogram is another one. It just is periodic, meaning it only shows what it shows while you're doing the procedure. Okay, this is a YouTube video link, echo tutorial, which is from the Mayo Clinic. It basically uses Doppler color flow to measure left ventricular volume, ejection fraction, fractional shortening, and circumferential fiber shortening. It can also be used to describe intracardiac blood flow, an origin of intracardiac shunts, diagnose pathologic lesions, evaluate regional wall motion, MI, transplant rejection. It does not provide a continuous assessment. The machines are portable and they're easy to do at the bedside. There are some challenges such as bandages, obesity, inability to turn the patient to get him into the desired position. Air trapping in the lungs may make it difficult for them to get a good image. So you'll definitely see echoes being done. They do them quite a bit. So that video I hope will be helpful. Radionucleotide imaging. Again, I have another video link. The book, like I said, it has a couple paragraphs on it. We don't go really super in depth. I think, be aware of which ones are invasive and which ones are non-invasive. Okay, so again, these are non-invasive. So this is basically the perfusion portion of the VQ scan, and I included a video link from Mount Sinai. It's a nuclear stress test. So basically, thallium-201 is injected and myocardial perfusion scanning is done with a CT. It can tell us how the stress test is done with nuclear imaging, and tells us how well we tolerate exercise. Blood flow is going to decrease if the heart is damaged. And then another one is just pulse pressure. Okay, it's kind of a real basic one, but just so you know what pulse pressure is your systolic minus your diastolic. Okay, so if we say like 120 over 80, you take those two numbers and subtract 80 from 120. So 120 minus 80 is 40. Okay, so then you would multiply your pulse pressure times your heart rate, which would give you an estimate for cardiac output. Okay, a normal pulse pressure is about 30 to 40. So if we take the 120 over 80 as textbook blood pressure, we would get 40. Can be used as a rough estimate for stroke volume, but it does not take in account actually peripheral vascular resistance in this P, just so you know. So that's where sometimes a peripheral or systemic is kind of mixed up, but when I looked it up, it was, I believe, peripheral. Right. Partial rebreathing. this is a modification, highlight modification of the Fick principle. It uses the Fick method applied to CO2 produced by the body and eliminated through gas exchange by the lungs. So basically, partial CO2 rebreathing is a method of cardiac output monitoring based on the modification of the Fick principle. So if you're, let me just finish looking at this part first. So you're looking at partial CO2 rebreathing images. Uses changes in CO2 elimination, so your change in your VCO2 and partial pressure of end-tidal CO2 in response to a brief period of partial rebreathing, and these are used to measure pulmonary capillary blood flow. So if PA pressures increases, then they will sometimes do a nitric oxide study. Okay, and this is something that they'll do in the cath lab, or in the cath lab. They do this to see if they're going to be responsive to different nitric meds. Okay, so if the pulmonary artery pressure increases, then they do this nitric oxide study. Okay, so or if it brings the pulmonary artery pressures down, then they are responsive. Okay, so then they'll consider giving nitric meds, and they can administer those medications with a pump, kind of like you would with an insulin pump. So if you work in the pulmonary function lab, it might be something that you might participate in. Where they do a FIC, they call it. They have to do a FIC where they bring in the nitric. All right. Now we'll be talking a little bit more about our invasive catheters. Okay, so indwelling catheters. We should all know kind of what a catheter is by now. A hollow tube that's inserted into the body cavity, a duct or a vessel to allow the passage of fluids or to distend a passageway. So we're going to be looking at where these different lines are inserted, how far the lines go, where the tip is located, what type of blood we can draw from it, and how are they different from each other. So, whether it's a catheter is in a vein or artery, it's still considered a catheter. So some of the pros and cons of having indwelling catheters, I'm sure you have a pretty good idea what some of them are by now. A good would be providing easy sampling, easy access, continuous monitoring, pressure monitoring, avoid having to always repeatedly poking the patient, to avoid sticking them all the time. However, unfortunately, they also have some bad qualities to them, infection probably being the most common, thrombosis or blood clots, and they're not always reliable because of improper placement or management. You can also make the readings inaccurate. So we'll talk about a couple different invasive measurements here. Thermodilution. Yeah, I knew when I said that SVO2, it was invasive, but that's why I was like hesitating there a minute. So these are all invasive of ways to measure our cardiac output. So thermodilution, VIX, continuous SVO2, and ultrasound. Well, it depends on what kind of ultrasound, but we'll talk about these here. So thermodilution. I'm pretty sure I have a slide on this. If I don't have it, the video link, I will add it to it. So I should have a video link, I think, in the next slide. The problem with this recording thing is I cannot go back on the previous slide for some reason. It doesn't let me. So I'm hoping I have on the next page a YouTube of the Swan-Ganz thermodilution pulmonary artery catheter. So showing how that is done. And back in the day they used these quite a bit, but you'll still see them out there, but not as often. So it's basically, they inject a cool fluid, it's usually a syringe that's on ice, and they're looking for a temperature change. Okay, so the temperature change is detected in the pulmonary artery. The time of the temperature change then is recorded, okay, so how long it takes for the temperature to change, and then the time it takes for the temperature to change is inversely proportional to the cardiac output. So it's a calculation basically, okay. The pulmonary artery catheter thermodilution method is considered the most accurate and reproducible method for cardiac output determination, and the one to which all other methods are compared. We don't see it as often due to the risks, and there's no real change in patient outcome, so that's why we don't see it as much. So you need to have a cardiac computer and a thermodilution pulmonary artery catheter placed. The temperature change is equal to the blood flow rate. So they measure, and this is all within the monitor, 3 temperature measurements are taken 1 minute apart, and then the average is used. So the more time it takes for the temperature to change, that is kind of equal to or reflective on a lower cardiac output. Okay. Let me see when I click. Yes, I thought I had. Oh, my crazy fingers. Hold on one second here. So yes, I do have a video link. I'm glad. So go ahead and watch this, and I'm hoping I can explain it to you. So they have to float that pulmonary artery catheter, and you can kind of see that in the previous video, where it wedges basically in the pulmonary artery. Alright, Fick's method, okay? This is taking a bunch of calculations here, okay? So, you can, this is also talked about in chapter 16 in Wilkins. So the Fick principle indicates that the cardiac output of the heart can be calculated if the oxygen uptake, your VO2, or your oxygen consumption, is measured in the amount of CaO2, your oxygen content, your little a, oxygen, your arterial oxygen content, and your CVO2, your mixed venous blood, is known. Okay, so you see that there in your equation. So you basically take your whole body oxygen consumption, your VO2, and divide that by your Ca minus your CVO2 times 10. Okay, so if we do the math on this particular problem, your cardiac output then should be about 5 liters. Okay, this is considered the gold standard to measure cardiac output. It is rarely used though in the ICU. Patients are too sick to get on a treadmill, because that's what you're going to need, is them to be on a treadmill, as in this picture. So in order to measure this, you need to collect inspiratory and expiratory gas samples, obtain arterial and mixed venous blood samples. The patient must be in a steady state at the time, so meaning their heart rate has to be unchanged for about 1 minute with the same workload. Based on the fact that cardiac output can be calculated, the oxygen consumption in the arterial oxygen content and the mixed venous oxygen content are simultaneously measured. This is very difficult to use regularly and is not popular in the clinical setting. Okay, so your answer, if you do the math, should be 5 liters per minute, which is our average cardiac output. Okay, so this is estimating, again, estimating your steps to the Fick's, I don't know why I can't talk, Fick's method. You're estimating your VO2, normal being about 125 mils per minute per meter squared. You have to look at your body surface area. Again, if we do the calculations on this, so the 125, just so you know, that 125 mils per minute per meter squared then is actually equal, because you have to take the body surface area. Okay, so that's where we get the 250 mils per minute. Okay, so don't think that that's an error. It's just saying what you're taking to get the calculation. Okay. Estimating VO2 is not ideal. We prefer to measure cardiac output using a metabolic cart, mainly because many of our patients really don't have a normal VO2. Okay. And using this particular calculation, they're doing a body surface area of 2 is how they got then, the 125 times the 2. All right, I'm just looking. Yeah, so the 3 steps then are required are calculating the expected VO2 or the oxygen consumption, and then calculate the arterial and the mixed, and then calculate the cardiac output. So we kind of saw that in the previous equation. All right, this is the one that I was talking about with the article that I have listed for you. I want you to read through that and then post a little comment after you've read it on continuous SVO2 monitoring. So if your oxygen consumption, your hemoglobin, and your SATs are constant, changes in your SVO2 should be reflective as a change in cardiac output. Okay, this again can use another equation. Okay, continuous SVO2 monitoring allows minute-to-minute assessment of total tissue oxygen balance, basically the relationship between oxygen delivery and oxygen consumption. So there has been significant correlation has been shown between cardiac output and SVO2 in critically ill patients who are in a steady state, but SVO2 has not been found to correlate as well with post-op cardiac patients or mixed populations of critically ill patients. So, I mean, it's another tool to use. And like I said, I kind of want you to read this article and see what you think about it. Kind of just explains it a little bit more. All right. I think it's kind of a cool way of looking at cardiac output. All right, a couple more. Pulse contour monitoring. This is like this PICO Plus. It basically is an invasive arterial pulse contour analysis. It's considered minimally invasive, but it is still invasive. And is an indirect method used to assess cardiac output. Cardiac output is computed from a pressure pulsation on the basis of a criterion from the machine or the monitor. The APC, which is arterial pressure continuous, provides a beat-to-beat cardiac output measurement and permits preload assessment using volumetric parameters and to help guide fluid therapy. So this is just another tool you may see out there. Ultrasound, probably something that you're a little bit more familiar. This uses volume of flow in liters per minute. It can be calculated. There's 3 different ways that you may see this: a transesophageal, a transtracheal, or an intravenous Doppler ultrasound. Transesophageal is one that they actually put into the esophagus. It sits at about the 4th or 5th vertebrae. The probe can stay in place for up to 4 days without problems. Position posteriorly to assess descending aortic blood flow. Okay, so keeping in mind what blood flow you're looking at. tracheal ultrasound attached to the end of an ET tube stays in continuous contact to the tracheal wall, and it can provide measures of flow that can correlate with stroke volume, and this is good for trending to kind of see where how it's trending. And then our last slide here is intravenous Doppler ultrasound. It involves a transducer mounted on a pulmonary artery catheter and positioned in the main pulmonary artery, and it also has a moderate correlation to thermal dilution. Okay, so that is all I have for today.